Thank you, Dr. Aya, for this nice presentation. And may I ask Dr. Maha Elnoby to present her talk about the crucial role of radiology in diagnosing CNS traumatic vascular injuries.
السلام عليكم. معانا مها مدرس النيورو. Okay. السلام عليكم. Today we will talk about the crucial role of radiology in diagnosing CNS traumatic vascular injuries. What are the ILOs? First, definition of traumatic cerebrovascular injuries. Mechanism of traumatic cerebrovascular injuries, types of vascular injuries of the brain, when to image and the type of image, and Denver, we will talk about Denver scale and the grading of vascular injuries. Introduction. Traumatic cerebrovascular injuries is a serious complications of traumatic brain injury. It has an incidence of about 1 to 9% of cases, according to the recently published views at 2018 and 2019. The most common mechanism of traumatic cerebrovascular injuries is actually blunting trauma, while penetrating trauma is less frequent. Only about 37% of these patients have clear symptoms of brain ischemia at first presentations of traumatic brain injuries. So, blunt cerebrovascular traumas with non-treated neurovascular images and have a risk of ischemic stroke of about 30 to 40%. So, early identification of cerebrovascular injuries through implantations of proper radiological screening criteria and appropriate management may therefore improve the patient's outcomes. What is the mechanism of traumatic cerebral vascular injuries? Blunt cerebrovascular trauma, and it is the most common. It is related such as to motor vehicle accidents or contact sports. Blunt injuries can result from sudden acceleration, deceleration, hyperextension, hyperflexion, and rotational trauma. In general, number 2, penetrating trauma. It's less frequent, but it's more dangerous. Penetrating trauma can be low velocity or high velocity. Low velocity mechanisms such as stab wounds. It causes vascular damage along only the path of the penetration. While high velocity such as gunshot wounds may cause injuries which extend beyond the penetration pathway. What are the types of vascular brain injuries which can be caused by the trauma? The spectrum of post-traumatic can affect both arterial and venous vasculatures, like arterial dissection, traumatic aneurysm, arterial transection, arteriovenous fistula, and venous thrombosis. But what is the best type of image? CT angiography represents the imaging technique of choice because it is widely available, can be easily and enable significant faster diagnosis of blunt traumatic cerebral vascular injuries. Digital subtraction angiography, but it takes longer acquisition and it can be the next step after CT angiography. MRI or MRA, but less frequently used in the emergent setting because they have more acquisition time and sensitivity to metallic artifacts. MRI with vessel wall imaging allow direct visualization of arterial wall, might improve diagnostic accuracy of blunt cerebrovascular injuries. When to image? The Denver criteria is used for imaging or screening criteria, which is a screening criteria used to determine when CT angiography of the neck is indicated to blunt cerebrovascular injuries. The Denver criteria was initially developed in 1996, modified in 2005 to limit cervical spine only, then expanded in 2012 to include the additional craniofacial and neck thoracic injuries. Subsequently, the Denver criteria has been expanded to include all cervical and spine fractures. The screening criteria is classified according to signs and symptoms of the blunt cerebrovascular injuries and risk factors. Modified Denver criteria, actually it is determined by the neurologist and neurosurgeons. According to the presence of a specific, what is this? According to the presence of suggestive signs such as cervical prurigo, expanding cervical trauma, arterial hemorrhage, neurological deficit, or the type of the trauma such as high energy trauma or high risk subluxation, left fractures, whatever يعني هي حاجة neurosurgery أو neurologist. Grading of vascular injury. The grading of vascular injury can be assessed by the using of the Denver scale, and we must not confuse between Denver scale and Denver criteria. The Denver scale, so we call our Bevel scale, is a 5-grade radiological classifications system for the blunt cerebrovascular injury. This scale classifies the feature of vascular injury into 5 grades, with increasing the risk of brain ischemia in relation to higher grades of arterial damage. Grade 1 As we see here, it's a minimal luminal irregularity or intramural hematoma or dissection which take less than 25% or make luminal narrowing less than 25%, like this one. Grade 2, intramural hematoma, more than 25% luminal narrowing, like this one, or raised intimal flap. Grade 3, pseudoaneurysm. Here we can see pseudoaneurysm of Denver scale type 3. Grade 4, complete occlusion of the vessel. Grade 5, transection with free extravasation of the contrast. Pseudoaneurysm, arteriovenous fistula is often included with transection in grade 5. The risk of stroke increases with increasing the grade of carotid artery injury. Grade 1 has 8% risk of stroke. Grade 2, 14% risk of stroke. Grade 3, 26. Grade 4, 50. Grade 5, 100% risk of ischemic stroke. The risk of stroke does not correlate with increase the grade of vertebral artery injury. Grade 1, 6%. Grade 2, 38. Grade 3, 27. Different ratios, not associated with the grade. So we will talk about the cases. مشكلة البلانت cerebrovascular injuries إن السيمبتومز ممكن تبقى early أو late، يعني ممكن العيان يجي early blunt trauma CT brain normal بعد أسبوع أسبوعين يدخل في ischemic stroke. Case number 1, history of the patient in 6 decades of life involved in a car accident. Here we see a non-contrast enhanced CT bilateral fractures of the lateral mass of cervical vertebrae with involvement of the transverse foramina. When we make CT angiography, we can see that the right vertebral artery, the left vertebral artery shows lack of opacifications with luminal narrowing more than 25%, which includes that it means that grade 2 Denver scale. When the patients make MRI, we saw that the area of diffusion restriction, tiny impulse diffusion restriction in the right cerebellar, which is indicating an embolic origin from the left vertebral artery, which was occluded. Grade 2. Case number 2, history of patients at the beginning of the 3rd decade of life involved also in a car vehicle accident. This is the MRI of the patient, shows that the areas of diffusion restriction in the centrum semi-oval with true diffusion in the ADC. MRI demonstrates distinct narrowings in the supraclinoid parts of the carotid artery and the cavernous portion. When CTA angiography was done, actually CT angiography was done three weeks later because it was felt that it's not just narrowings or occlusion. When it was done after 3 weeks, we found that CT angiography shows a bilobed aneurysm, supraclinoids and cavernous portions. When CT angiography map was done, it's through pseudoaneurysm في supraclinoid portion. This is grade 3. Pseudoaneurysm is grade 3. Case number 4, a patient in the early 5th decades of life following a motor vehicle accident. We can see non-enhanced CT demonstrates fracture for right supraarticular process of C6 vertebrae. When CTA was done, shows complete lack of opacification of the right vertebral artery. Coronal view also shows that non-opacifications of the right vertebral artery. This means that complete occlusions following motor vehicle accidents, so it's a grade number 4. Case number 4, 34 years old patients sustained a shotgun injury to the head. CT shows bilateral frontal fractures with a retained multiple shotgun pellets in the head bilaterally, with close proximity to the MCA origin. When CTA was done, it was found that close proximity caused transection of MCA with extravasation of the contrast. This is grade number 5. Case number 5, 19 years old patient with a history of road traffic accident and facial fractures 3 weeks duration ago. Patients presented with total ophthalmoplegia, proptosis of the left eye, and suspected cavernous sinus thrombosis. Patients الحالة دي معمولة عندنا في دمرداش، فالبيشنت عمل MRI cavernous sinus. Okay, this is the T2. Okay, what can we see in the T2? Again, we can see retroorbital edema, proptosis of the eye, with superophthalmic vein can enlarge it. Coronal T2, retrobulbar edema في ال extraocular muscles, superior ophthalmic vein distended, while cavernous sinus shows preserved signal voids of internal carotid. CTA without contrast, or T1 without contrast, the same findings. Superior ophthalmic vein with signal voids preserved, so mostly no cavernous sinus thrombose. MRA was done. We show that there is high flow communication between the intracavernous portion of the left internal carotid artery and the cavernous sinus, with the superior ophthalmic vein taking the same signal as the arteries. MRV was done. Dilated left superior ophthalmic vein. T1 with contrast showing preserved contrast enhancement of the cavernous sinus, dilatation of superior ophthalmic, multiple signal voids within the cavernous sinus. All of these findings together, MRA, which shows that distended superior ophthalmic vein with high flow communication between the internal carotid and the cavernous sinus, together with MRV, which shows dilatation of superior ophthalmic vein, with LT1 with contrast, which shows that the cavernous sinus is patent with multiple signal voids are seen, are diagnosing that there is a direct carotid cavernous fistula in this case. Take a home message: post-traumatic neurovascular complication might lead to severe consequences and be life-threatening. So early diagnosis is crucial to optimize patient management and improve clinical outcomes. Thank you.
Thank you very much, Maha, for your nice talk. I have the pleasure to present